So it is a real pleasure and delight on behalf of Angela and I to welcome you here today for this last session of Sinai Innovations. And also, following Angela Diaz is like following a rock star and really defines what it means to be innovative within both a healthcare system and within the nation. And on behalf of all of us in New York and nationwide, Angela, I just wanted to publicly thank you for the incredible work that you have done here. It's really quite remarkable, so thank you for that. This is a relatively unique session for this program, as it focuses really on innovation in health services research, rather than what we typically think of biomedical innovation, which is technology, devices, new drugs, new procedures. And I thank the organizers for thinking about that, because when we look nationally, we realize that we spend more on healthcare in this country than any other nation in the world. We spend about 18% of our GDP on healthcare. And that's about twice as much as most Western nations, and it's a good 6 percentage points above our nearest, I would say, competitor. And that would be wonderful if we had results that matched that spending. But the reality is, we have the highest death rate of people, death rate amenable to healthcare of any other developed nation. And so we're spending a tremendous amount of money on healthcare and not getting very, very good results. And from my perspective, what that means is that we've got to change how we're delivering healthcare in this country. It's probably, our spending on healthcare is probably the single greatest threat to our American way of life if we can't contain it. And that's going to require innovation, because if we are to get a handle on healthcare spending and continue to provide high quality care and not do rationing, we need to think about how we can innovate to provide better care for more people at higher quality. And so I'm really thrilled that we're going to be able to have two keynote speakers who have thought long and hard about how to do this, and our four panelists, or four Mount Sinai panelists, whose research and work and clinical care is focused on that type of innovation. So let me begin by introducing our first keynote speaker, who is David Blumenthal. I was about to say, or I had written last night, that Dr. David Blumenthal is the new president of the Commonwealth Fund, until he reminded me it's been 5 years. It just seemed like yesterday that he was recruited to the Commonwealth Fund. For those of you who don't know, the Commonwealth Fund is a national philanthropy which is engaged in independent research on health and social policy issues. And although you may not have heard their name, you have seen all of their data and all of their reports on the front page of the New York Times. Dr. Blumenthal received his undergraduate medical and public policy degrees from Harvard. We will forgive him for that. He completed his residency in Mass General Hospital. We will forgive you for that too. Liz, we will forgive you as well. And before coming to Commonwealth, he served as the National Coordinator for Health Information Technology in the Obama administration. He had the charge of basically building an interoperable, private, secure, nationwide health information system and to support the widespread, meaningful use of health IT. Quite a job. Prior to his engagement in government service, he was the Samuel Thier Professor of Medicine at Harvard Medical School and the Chief Information and Innovation Officers for Partners Healthcare System in Boston. He, while doing that, was a practicing primary care physician, Director of the Institute for Health Policy, and Professor of Medicine and Health Policy at Massachusetts General Hospital. He has authored more than 250 books. I think about 50 of those I have on my shelf. His most recent is Heart of Power, Health and Politics in the Oval Office. I commend it to you. He is a member of the Institute of Medicine, of course, now the National Academies of Medicine, and has been on the editorial boards of our leading medical journals. David, am I correct? You were one of the founders of Health Affairs, is that, or chair? Academy Health, thank you, Academy Health. So it's a real pleasure to introduce Dr. David Blumenthal, who's going to talk to us about how do we care for high-cost, high-need patients.
Good afternoon. It's great to be up the street. Our offices are about 30 blocks downtown, down Fifth Avenue, so you're our community hospital here, so it's nice to make a visit. And I must admit, having spent most of my career at Mass General, that I kind of do miss the smell and feel and touch of a acute care facility, though I am a primary care physician by background. I'm going to talk about, if I can get the technology to work, there we go, making the health system work for high-need, high-cost patients. And I'm going to specifically talk about three things. First, why should we worry about this particular category of patients, and who are they, after all? I'm going to talk a little bit, since I was a professor once upon a time, I'm going to make a little bit of an academic departure and talk about a framework for thinking about improving the healthcare system, which I hope you'll find useful. And then I'm going to talk a little more specifically about what we know about what works for high-need, high-cost individuals. So why worry? Why worry about this group of patients? Well, there's one very important reason, and that is that they are our parents, our brothers and sisters, our aunts and uncles, our friends, our colleagues. They are everywhere in our society. They may not wear a label on their foreheads, but they are a very important segment of the patients that we care for. And they also, because they have needs and because they are in contact with the healthcare system, they suffer most from its failings. They are more likely to be the victims of safety problems, of quality failures. So they use the system a lot and they need better care from it. So there's a very important humanitarian and communitarian reason to be worried about them. But in this age, of course, economics is a perpetual concern. And one of the reasons why we worry about these, and Dr. Morrison made a very nice, set a very nice context for this, is that this is the group of patients. One way of categorizing them is that they are disproportionate spenders. Nationally representative data from the Medical Expenditure Survey shows that they account, 5% of our population accounts for about 49% of our healthcare spending. So very concentrated spending in a very small minority of our patient population. Since Dr. Morrison began with an international perspective, I want to continue that theme a little bit and point out that we are not alone in that phenomenon. This, as a matter of fact, wherever you look in the developed world, you see the same concentration of expenditures in a small group of individuals. So in Ontario, our neighbor to the north, the sickest 5% of the population account for 61% of hospital and home care services. In Scotland, the sickest 2% account for 50% of hospital and pharmacy resources. And the other thing to be aware of with this population is that they are not by any means all elderly. Many are not. But the elderly contribute disproportionately to this category of individuals. And the demographics of our society make it almost inevitable that this 5% is going to grow, maybe not in percentage terms, but in absolute numbers. So as a burden on our healthcare system, the very sick and the very needy are going to be more and more present for us as a challenge. That means very clearly that if Mount Sinai Health System or my home, once upon a home system of Partners Health System in Boston, or the University of Pennsylvania health system, where I was on the board for many years, if they want to do well by their patients, and if they want to do well financially, especially in this world of increasing financial accountability, they simply have to find a way to take care of these patients in the most effective way possible. Who are they? Well, first of all, they do have certain general characteristics. They are more likely to be elderly. They're likely to have multiple chronic conditions. They're disproportionately poor and face material hardships independent of their medical care needs. And they are more likely to be near end of life, though they are not by any means all near the end of life. Functional limitations play a major role in exacerbating their conditions and adding to their healthcare expenditures. So populations with 3 or more chronic conditions that have a functional limitation have average expenditures about 3 times those that don't have a functional limitation. So there's something about this limitation, independent of the illnesses that are associated with it, that predicts high cost and high need. Behavioral health issues are also highly prevalent in this population. Take any disease, any chronic illness, asthma, COPD, congestive heart failure, coronary artery disease, add mental illness, and you about double their average annual spending. Add a substance abuse issue to the mental illness, and you quadruple or quintuple their expected annual expenditures. So behavioral health is a big factor in addition to functional limitations. I mentioned that they tend to be near the end of life, and that they're not all near the end of life. Joanne Lynn who of course studies end-of-life individuals, has provided a categorization of the various patterns of progression, the natural history of patients who are near end of life. And that progression, those patterns also are replicated in this high need, high cost population. It is a heterogeneous population. Some, being near end of life, die after a short acute illness. Some follow a stutter step pattern in which they have periodic exacerbations and then recover, maybe not to their prior level of functioning, but pretty much recover, and then go a period of time and have another setback. And then some, the third category on the lowest category on the left, is follow a pattern of slow, relentless deterioration. And that is perhaps most characteristic of dementia as the underlying cause of medical issue. I threatened you with an academic detour, and here it comes. So I want to share with you a way that I think about how to improve healthcare system performance, which I think is relevant, extremely relevant to this population, and provide some guideposts for how to proceed at a general level as you think about health system reform for this and other populations. So the Crossing the Quality Chasm, which was a landmark Institute of Medicine report, now about 18 years old or so, laid out a framework for how to improve the quality of care in the United States healthcare system. Had an appendix with a model of the key components, the moving parts of a healthcare system. And this is a very, very simplified version of that model. And basically what it asserts is that overall health system performance is a function of the interaction and the direct effects of things called microsystems and macrosystems. So it sounds simple. What are microsystems? Microsystems are where clinicians and patients live. They're where the rubber hits the road, what systems analysts call the sharp end. They're where care is provided and received. They're things like emergency departments, ICUs, operating rooms, admitting departments, clinical practices. And in fact, when most clinicians and patients think about improving the healthcare system, they tend to think about those specific systems, microsystems, which are where their experience lies. To make the life of a clinician easier, it is often the improvement of the check-in process, or the way in which a room turns over, or the way in which equipment is made available exactly at the point of care, when it's needed, where it's needed, that comes to mind most frequently. And those are relevant aspects of microsystem behavior. Macrosystems are what systems analysts call the blunt end. They are systems that wrap around microsystems. They are things like government programs and regulations, Medicare, Medicaid, the process of regulation of quality. There are also things like the health plans that operate and how they pay, the accrediting organizations that swoop in and accredit or fail to accredit healthcare organizations, the national boards that determine what gets on the tests that clinicians have to pass in order to be licensed for practice or certified as a specialist. Now, it turns out that we have learned a fair amount through health services research about how to improve microsystems. As a former health services researcher, I understand why that's true, because microsystems are numerous. So you can create a sample that's large enough to do a study that has significant results, and therefore you can get it published. So there's an incentive in the academic, a built-in incentive in the academic community to focus on microsystems. And they're also what we understand, and they are in direct contact with patients, so they matter. And there's a lot we know about what works. My favorite is the reference here to reminder systems. I wrote a paper reviewing the literature on reminder systems about 25 years ago. Reminder systems are whatever you use to remind a clinician to do something that they should do for a particular type of patient. It could be to check the feet of diabetics. It could be to give influenza immunization to adults or children. It could be to give normal childhood vaccinations to children. Whatever it is, it works. You can increase compliance with guidelines dramatically if you just remind clinicians of what they need to do. And yet, reminder systems have never been prevalent in our healthcare system. We know it works, but it's not prevalent. Computerized decision support, CDS, and provider order entry, another example, one that I wrestled with as in government a lot, one that I used as a clinician at Mass General Hospital. There are good randomized controlled trials that show pretty dramatic improvements in quality of care, reductions in adverse drug events, more compliance with normal prescribing and expected prescribing behavior if you have computerized decision support and physician order entry. That did not spread in the United States until the federal government put massive incentives into requiring that it be used widely. The PACE program, for my colleagues from Geriatrics, this is a familiar program. It's been, I'm going to say a little bit more about it later, but it's been demonstrated to be successful in a number of dimensions. So the common theme here is that things that we know work don't spread. They're lost in translation. They simply don't go from the model, the demonstration, to widespread application, unless something like the federal government marches in and throws billions of dollars at it, or puts regulations that with associated penalties into effect. And that is not a common event, given our attitudes toward government. So what's the problem? Well, my theory is that we have failed to create macro systems that support the dissemination and use of the microsystem of progress that we have engineered and proven through health services research. To put it another way, real delivery system reform requires that we make it easy to do the right thing. Easy to do the right thing. Right now, people who want to reform our health systems have to be heroes and altruists in order to make change. They come to work every day and they fight against all the prevailing forces to make change happen. And the fight is exhausting and discouraging and demotivating. And the fact is, we can't depend on people to be heroes day in and day out. We have to make it easy and logical, the easier thing to do the right thing. I'm going to take a little detour now and talk about some of the things that we know or seem to know that work in caring for high-need, high-cost patients. So we asked Jerry Anderson, an economist from Johns Hopkins, about 3 years ago, to do a review of the literature on how this population is cared for. And he, after reviewing the usual scores and scores of papers, tried to boil down what he'd learned into a few simple observations, and these are some of those simple observations. He said that successful programs stratify patients by common needs. So high-need, high-cost patients are heterogeneous. If you treat them all the same way, you're likely to be fairly inefficient in your programs. So important to match the patient to the clinical intervention. It's a pretty basic idea for clinicians. Do the thing that the patient needs rather than do something else. Invest in care coordination. We talk a lot about care coordination. Whether we invest in it or not is another thing altogether. Shift care from institutions to communities. Get people out of institutions. Care for them in their homes. Integrate medical, behavioral, and social services. I'll come back to that in a moment. And then last, give providers flexibility in allocating resources. Don't tie their hands to doing only what's reimbursable according to billing codes. This, I think, is in some ways the key that unlocks all the other points in this list. So there are a few examples that I'm sure are very familiar to my colleagues in the geriatrics and palliative care world. One of them is the CareMore program. CareMore was founded in Los Angeles in 1993. It was recently acquired by Anthem, the large insurance company. It operates Medicare Advantage plans, that is, plans that take prepaid premiums for taking care of Medicare patients. They're kind of like HMOs. And also operates delivery systems in about 6 states. It's probably more like 8 or 10 states now. They have begun subcontracting their work out to other institutions. For example, Emory has contracted with them to take care of their high-need, high-cost patients. That's a delivery system intervention, not a payment intervention. Their key technical changes involve the use of something called an extensivist. These are physicians who specialize solely in the care of these very high-need, high-cost patients. And they've also been innovative in their use of new services like Lyft. So they contract with Lyft to bring their patients to the clinic. They've reduced hospital readmissions. They've reduced SNF days. They need to be studied thoroughly, but there are indications that they are lowering costs. Their patient satisfaction data is very good. PACE, I mentioned that earlier. This is a venerable, storied initiative that began in San Francisco in 1971 to take care of extremely ill and vulnerable Asian American individuals. They have about 120 programs. There are 38,000 enrollees. It circles around or concentrates on a structured daycare center with interdisciplinary teams, and they have a flexible spending model. They reduce hospitalizations and mortality, and they are very, very well received by their patients. This is an advertisement for something called the Commonwealth Care Alliance, which is a program in my backyard in Massachusetts. Says, I'm what you might call complicated, and you're just our type. This is not something that I, as a clinician, thought I would be especially attracted to, is this very complicated patient, but this is the specialty of the Commonwealth Care Alliance. They have about 60 sites in Massachusetts, 17,000 members. They use interdisciplinary teams. They blend Medicare and Medicaid funding, which gives them flexibility. And they reduce hospitalization and nursing home use and improve care experiences. So to care for this population, we don't need to reinvent the wheel, but we do have to face some challenges. The most important of those is misaligned incentives. We don't have financial incentives to care for these complicated patients in efficient ways. And that is because we are still predominantly a fee-for-service environment, and more care use is more revenue. Once the incentives are lined up, we still face a problem of culture. When I was being trained as a physician, I was told, if you want to do something, if you want to make sure something's done right, do it yourself. That's not a practical rule for our healthcare system, but it's a pretty common way in which at least the mentality of physicians gets formed. We need to move from this singles match mentality to a team mentality in healthcare, and that's a huge cultural effort. We also underinvest in social services in the United States. This is a graphic from Betsy Bradley's pioneering work on the combined expenditures in in OECD countries on a combination of social services and healthcare services. You see in the middle there, circled, the US experience. When you add our social spending and our healthcare spending, we're about average in the OECD, but it doesn't require a microscope to see what the difference is, that we disproportionately spend that investment on medical services and disproportionately underinvest in social services. So what are we doing about this? Well, the Commonwealth Fund has formed a 6-foundation collaborative, 5 peer foundations, to try to improve the care of high-need, high-cost patients. We announced this in a journal article in the New England Journal of Medicine a couple of years ago. The co-authors are all CEOs of these respective foundations. Perhaps the most important element of this coalition, the most important product to date, has been the formation of a playbook called the Better Care Playbook for complex patients. It's online at this URL. It offers anyone who wants to get these programs started a full accounting of all the existing programs and what their strengths and weaknesses are and how to make contact with their leaders so as to get a head start in trying to emulate what they do well and avoid their mistakes. We've had about 45,000 unique visits to the website, 180,000 plus page views in the 2 years since it was launched. It's constantly being updated and improved. And it includes an ROI, return on investment calculator, specifically for social investments, because it's our theory that in order for social services to be applied in our particular political environment, healthcare systems are going to have to take the lead, and you're going to have to convince them that they're going to get a return on that investment, that non-traditional investment. And there's data to support the idea that that might be possible. So on the far left here, you see a study of housing support pilot from the health plan of San Mateo, which reduced annual monthly healthcare expenditures by their patients by about $4,300. You see a pilot with food as a prescription item from Geisinger Healthcare for diabetes, which resulted in blood sugar levels and reduced blood sugar levels and improved savings. And you see a transportation initiative on the far left that saved about $3,400 per patient per month. This is the kind of data that may convince a risk-bearing health system to invest in these non-traditional medical services from high-need, high-cost patients. So that's what I had to say. I'd be delighted to take some questions. I don't know exactly what the plan is now, but it's been a pleasure to be here. I know that Sinai has its long history of pioneering in this area. It gives me hope that it may be a pioneer in this particular field as well. Thanks very much.